Dear students, let me discuss a very important topic in the cardiovascular system, that is the mitral valve prolapse. There were few questions which were being asked in the previous entrance exams on the mitral valve prolapse as well. So let me take up this topic and discuss. Now, if you say this mitral valve prolapse, what exactly this mean? Remember, this is the normal mitral valve, right? This is the normal mitral valve. But you see in these patients with the mitral valve prolapse, what is happening is the valve, that is a mitral valve, it is prolapsing into the left atrium. Right? The mitral valve, it is prolapsing into the left atrium. That is what is called as the mitral valve prolapse. Now, let me tell you, there are certain other names for this particular mitral valve prolapse. The other names for the mitral valve prolapse is, they are also called as, or this mitral valve prolapse is also called as Barlow syndrome, right? It is also called as Barlow syndrome, or the other name which is given is billowing mitral valve, right? The other name which is being given is the billowing mitral valve, or it is also called as, right, or it is also called as floppy valve syndrome, right? It is also called as the floppy or floppy valve syndrome. Right? So these are the various other names of the mitral valve prolapse. Now, let me discuss what exactly will be the etiology of the mitral valve prolapse, right? And I will be discussing what will be the clinical features in these patients with the mitral valve prolapse and what will be the important auscultatory finding, right? The auscultation is very important in these patients with the mitral valve prolapse, and how do you diagnose these patients of mitral valve prolapse, and what is the treatment you give in these patients with the mitral valve prolapse. Let me discuss them. Now, let me show you a question which was being asked previously in this topic of mitral valve prolapse. Right? So, in the discussion of the theory, I am just showing you the questions which have been asked previously, and accordingly, I am discussing the entire topic. But remember, in the separate questions section of my app, you will be having completely a new clinical based questions which have been framed by me, and as well as image based questions you will be having in a separate section. Now, so you see this question here. True regarding the mitral valve prolapse syndrome is all except more common in female, mostly symptomatic, high incidence of arrhythmias, transient cerebral ischemia can occur, right? So, which is the true statement is what the question is asking, and which is the except, in the sense, which is the incorrect statement among these options is the question. Now, what I'll do is I'll just discuss the entire mitral valve prolapse, right, and the clinical features, and then we will see this question, what will be the answer. Now, so if you see this mitral valve prolapse, let me tell you that in these patients with the billowing syndrome or flappy valve syndrome, either a single mitral leaflet will be prolapsing into the left atrium, or both the leaflets will be prolapsing into the left atrium. So, in mitral valve prolapse, it is one or both leaflets, right? One or both leaflets will be prolapsing into the left atrium. Now, the question is, during which part of the systolic cycle, during which part of the cardiac cycle is the mitral valves prolapsing into the left atrium? So, the point what you should remember is, whenever the left ventricle is undergoing the systole, normally what should happen is the mitral valve should close, right? Whenever the left ventricle is undergoing the systole, the mitral valves should close normally. But what is happening here is, instead of getting closed, the mitral valves are prolapsing into the left atrium during the left ventricular systole. So, the prolapse prolapse, it occurs during the systole of right, during the systole of left ventricle. All right, next. Now, once the mitral valve is prolapsed into the left atrium, there may be certain chances that, right, there may be certain chances that the blood from the left ventricle may regurgitate back into the left atrium. Right, the blood from the left ventricle may regurgitate back into the left atrium. So, whether mitral regurgitation will be present or will not be present, it all completely depends upon the severity of the mitral valve prolapse. All right. So, now you see this point. This mitral valve prolapse may or may not be associated with mitral regurgitation. Next, in which group of individuals is this mitral valve prolapse very commonly seen? Remember, this mitral valve prolapse is commonly seen in young women. Right, this mitral valve prolapse is commonly seen in young women, right? And in certain rare conditions, right, in certain rare conditions, this mitral valve prolapse can also be seen in older individuals of more than 50 years. Okay, so the point what you should remember is the occurrence of the mitral valve prolapse in elderly individual is rare. Now, there is a multiple choice question here regarding the older individuals. What is that is, when the mitral valve prolapse is seen in older individuals, right, when mitral valve prolapse is seen in older individuals, most of the patients, they are males. See, what did I tell you? Most of the time the mitral valve prolapse occurs in young women. But if mitral valve prolapse occurs in elderly individuals, that group of population is mainly the males. And most of the time, the mitral valve prolapse, whichever is occurring in elderly individual, it is associated with the mitral regurgitation. Right, it is associated with the mitral regurgitation, and that too, it is associated with the severe mitral regurgitation. Right, and when the individual has association of a severe mitral regurgitation, and this will require the surgical treatment. Right, this will require the surgical treatment. Is this clear? Now, after this, let me tell you another important point. What will be the presentation, right? Remember, these individuals, they present with the atypical chest pain, or they may have even palpitations, right? And certain times they can have even panic attacks. That will be the presentation of these particular patients of the mitral valve prolapse. And the other point is, how do you diagnose this mitral valve prolapse? Diagnosis of mitral valve prolapse is being done by a two-dimensional echocardiography, right? Now, before that, let me tell you the etiologies where you come across this particular mitral valve prolapse. So, if you take the etiology of the mitral valve prolapse, remember an important point, the etiologies where you come across is, most commonly the mitral valve prolapse is seen in those individuals who are having the Marfan syndrome. Right, the disease is one of the most common cardiovascular system manifestation of the Marfan syndrome. Next, the other point is, the mitral valve prolapse, it is seen in almost 20% of patients with ostium secundum type of ASD, right? Ostium secundum type of atrial septal defect. So these are the two common clinical scenarios where you come across the mitral valve prolapse. One is in Marfan syndrome, and 20% chances in case of the ostium secundum type of the atrial septal defect. Now, let me tell you the clinical manifestations or the clinical features of these patients with the mitral valve prolapse. If you take the clinical features of these mitral valve prolapse, most of the time, right, most of the time, these patients, they are asymptomatic. Right? Most of the times, these patients, they are asymptomatic. And let me tell you what makes them to get diagnosed to have the mitral valve prolapse. So, most of the times, they are asymptomatic, and the presentation of these patients with the mitral valve prolapse is usually benign. Right? It is usually benign. And these patients, they may present with, right? These patients, they may present with non-specific chest pain, right? They may present with difficulty in breathing, that is dyspnea, right? And they may present with fatigue and as well as palpitations. Right? And as well as the palpitations. So this will be the clinical manifestations. Now let me take up one particular symptom and let me discuss why they will have that particular symptoms. First, let me discuss about the palpitations. So if you see these palpitations, one of the most common symptom what you come across in the patients with the mitral valve prolapse is the palpitation. This is the most common presenting symptom. Now, why do you get this particular palpitations? The reason why they will have palpitations is because these individuals, they will have ventricular premature beats, right? They will have ventricular premature beats. Now, let me explain you why they will have this ventricular premature beats. Now, you see this image over here. Now, in mitral valve prolapse, let me show you what exactly is happening. Now, this is your papillary muscle, which is attached to the endocardium, right? Which is attached to the endocardium. Now, when the ventricle is undergoing the systole, what is happening to the mitral valves? Mitral valves, which are in the open state, they are moving towards the atrium. But in mitral valve prolapse, what is happening is the mitral valve leaflets, they are not only moving towards the base of the mitral valve annulus, they are going beyond the mitral valve annulus. Now, what are being attached to the tip of the mitral valve leaflets? That is your chordae tendineae, they are attached to the tip of the mitral valve leaflets. Now, when the mitral valve annulus is protruding or prolapsing into the left atrium, what will happen is these chordae tendineae, they will pull the papillary muscles. Right, the chordae tendineae, they will pull the papillary muscles. Now, where are these papillary muscles attached? The papillary muscles, they are attached to the endocardium of the left ventricle. So that means what are the chordae tendineae doing? Chordae tendineae, they are indirectly exerting the stimulus over the endocardium of the heart. Now, when the chordae tendineae are exerting an indirect stimulus toward the endocardium of the heart, then this particular ventricle will get stimulated and there will be a ventricular premature beat, right? And there will be a ventricular premature beat. Now, because of the presence of this ventricular premature beats, these individuals, they will have palpitations. Is that clear? Now, after the palpitations, the next other symptom is the chest pain. So, if you take chest pain, this is also one of the frequent complaint, right? This is also one of the frequent complaint what you come across in these patients with the mitral valve prolapse. The point is the type of chest pain. The chest pain what you come across in these patients with the mitral valve prolapse, it is an atypical chest pain, right? It is atypical chest pain, right? Now, what do you mean by the difference between typical and atypical chest pain? Typical chest pain means that particular chest pain which is of the cardiac origin due to coronary artery occlusion. Now, the chest pain of the coronary artery occlusion will be with the following characteristic features. Most of the time, the location of the chest pain is retrosternal and the pain of the coronary artery occlusion increases on exertion. That is, while simple walking or doing routine day-to-day activities, the chest pain due to coronary artery occlusion, it increases. And once the individual takes rest, the chest pain of the coronary artery occlusion will reduce. And it all, see, whether it will reduce or not, it depends upon the severity of the coronary artery occlusion. But the point is, this particular pain of the coronary artery occlusion increases on exertion. That is what is called as typical chest pain. Whereas here, it is atypical chest pain. And it rarely resembles classical angina pectoris. Right? It rarely resembles classical angina pectoris. And what exactly is the etiology of the chest pain is uncertain. Right? What exactly is the etiology of the chest pain is uncertain. Next, the other important symptom in these patients with the mitral valve prolapse is the presence of dyspnea and fatigue. Right, the presence of dyspnea and fatigue. The presence of dyspnea and fatigue, this is another frequent symptom what you come across these patients. Now, why do you have this particular dyspnea? Remember, the dyspnea in these patients with the mitral valve prolapse is because if mitral valve prolapse is associated with, right, if mitral valve prolapse is associated with severe mitral regurgitation, then they may land up in pulmonary edema, due to which they will have dyspnea. Now, why do you think they have fatigue? Because when the patients have severe mitral regurgitation, the blood from the, that is significant amount of the blood from the left ventricle is moving into the left atrium instead of moving into the aorta. So what will happen to the cardiac output? That gets reduced. So what will happen to the perfusion to the entire body? That is reduced. And that is the reason why the individual will have fatigue. Next, the other important manifestations are the neuropsychiatric complaints. Right, the neuropsychiatric complaints. All right, now some of these patients with the mitral valve prolapse, they may have the panic attacks. Right, they may have panic attacks, and some of them have frank manic depressive symptoms. Right, some of them have frank manic depressive symptoms. And the other point is, some of these individuals, they may also have transient cerebral ischemic attacks. Right, transient cerebral ischemic attacks. And some of the individuals, they can also have stroke. Right. See, these neuropsychiatric symptoms, that is transient cerebral ischemia and stroke, is very, very rare. I'll tell you the reason. Now, you take in these patients with the mitral valve prolapse if they are associated with the severe mitral regurgitation. So, when they are associated with the severe mitral regurgitation, what will happen is the LA diameter increases. Once the LA diameter is increased, that is left atrium is enlarged grossly, that enlarged left atrium will be the focus of the impulse generation. It will be generating an ectopic impulse from the enlarged left atrium, and thereby the individual will land up in what is called as atrial fibrillation. So once the individual has atrial fibrillation, there is chance of the formation of the clot within the left atrium, and this particular clot can shower an emboli into the cerebral vasculature, resulting in TIA or stroke. That is the reason why you have this particular neuropsychiatric symptoms. Now, let me discuss what will be the important examination findings in patients with the mitral valve prolapse. So, if you see the examination findings, right, on examination, what will you observe? What will you see in these patients with the mitral valve prolapse? See, I have said you most of these patients are asymptomatic, right? And how are they diagnosed? They are diagnosed accidentally when the individual has come or when the individual has gone to the doctor for a routine checkup, And on auscultation, right, on auscultation, there is a presence of mid-systolic, right, mid-systolic ejection click, right, there is a presence of mid-systolic ejection click. And the name of this mid-systolic ejection click is, this is also called right, this is also called as non-ejection click, right. And they may also come to get diagnosed when they have accidentally undergone the two-dimensional echocardiography, right. The individual is posted for certain surgery and he wants a cardiology clearance, and for the cardiology clearance, the cardiologist has advised a 2D echo because he has found something abnormal on auscultation. And 2D echo has been done, and there they have found that the individual is having mitral valve prolapse. So accidentally, the individual may have got diagnosed by a two-dimensional echocardiography. But the important point what you should remember is the auscultation, right. Now, I have said you that there is presence of the mid-systolic ejection click. The mid-systolic ejection clicks, they are of high-pitched, right, they are high-pitched, and they are of short duration, right, they are of short duration, and these clicks, they are heard after S1, right, these clicks, they are heard after S1. Now, let me tell you the reason why they will have these clicks, and that too, this particular systolic clicks, they are multiple in number, right, they are multiple in number. Along with the clicks, right, along with the clicks, the other important auscultatory finding is, in these individuals, there will be also presence of a late systolic murmur, right, there is also the presence of a late systolic murmur. So this will be an important auscultatory finding. One is click and the other one is the late systolic murmur. Now, let me discuss why you have that multiple clicks and why you have that late systolic murmur. Let me discuss from this image. Now you see here, let me answer you why they have that particular multiple clicks. Now you take this chordate tendineae, right? You have multiple chordate tendineae which are attaching to both the mitral valve leaflets. Now, once the mitral valve, it is prolapsing, right? Once the mitral valve, it is prolapsing into the left atrium, all these multiple chordate tendineae are being stretched to the maximum possible extent, right? All these multiple chordate tendineae, they are being stretched to the maximum possible extent. And where do they give a pressure? They give the pressure to the papillary muscles. And for supporting the chordate tendineae, the papillary muscle also, they get a maximally stretched. Now, once the maximum stretching of your chordate tendineae, maximum stretching of your papillary muscles are over, then this particular chordate tendineae, they suddenly stop their further extension, right? This particular chordate tendineae, they will suddenly stop their further extension, beyond which if they extend, they get ruptured. So, once the maximum extension of the chordate tendineae is over, they suddenly get stopped. Now, the point where they suddenly stop their further extension will be auscultated as a click. Now, there are multiple chordate tendineae. That is the reason why you get the multiple clicks. Is that clear? Now, why do you get this particular late systolic murmur? Remember, the late systolic murmur in these individuals is because of the regurgitation of the blood into the left atrium, right? The blood from the left ventricle, it starts regurgitating into the left atrium when it is a significant mitral valve prolapse. Is that clear? Now, let me tell you another important finding, that is the complications in these patients with the mitral valve prolapse, right? Let me discuss the complications in these patients with the mitral valve prolapse. Okay. So, if you take this particular multiple ejection clicks, there is one important multiple choice question regarding the clicks. You see here, you come across this particular clicks, that is the mid-systolic clicks, in many other conditions as well, right? For example, you take in patients with aortic stenosis, they also have the clicks, right? You take in patients with the mitral valve prolapse, they also have a click. You take in a patient with the pulmonary stenosis, they also have a click. Now, how do you differentiate the clicks of the mitral valve prolapse from the clicks which are being generated due to other cardiovascular condition? So, this is the point where you need to do what is called as a dynamic auscultation. Right, this is the point where you have to do a dynamic auscultation. Now, you have to do dynamic auscultation by doing certain maneuvers which will increase the venous return, and you have to do dynamic auscultation by doing the maneuvers which will decrease the venous return. Now, for example, we will see the maneuvers which are being done we will see the maneuvers which will increase the venous return. Now, what are the maneuvers which will increase the venous return? Number 1, isometric hand grip. Number 2, when the individual does squatting. These are certain maneuvers where the venous return can be increased. The other maneuvers are also there. That is whenever the individual lies in the supine position from standing position, or whenever the individual does a passive leg raising. All these clinical scenarios, like all these maneuvers, the venous return is increased. Now, whenever the venous return is increased, let me tell you what will happen to the click, what will happen to the murmur. What will happen to the click? The click is delayed. Right, the click is delayed. Why? Because all the maneuvers which will increase the venous return has gone to the right side of the heart. So what has happened to the quantity of the blood on the left side? On the left side, the blood quantity, the blood volume is reduced. So what is the time required for the contraction? The time of contraction is increased because the volume of the blood is less. So the rise of pressure within the left ventricle is less. So that is why the left ventricle contracts slowly. So when the left ventricle is contracting slowly rather than normal, what will happen is the mitral valve, they prolapse, but they prolapse little late. So that is the reason why the click is being delayed. Now, what will happen to the murmur? The murmur, it gets shortened. So why do you think the murmur gets shortened? It is only when the mitral valve prolapse occurs significantly, then only the blood regurgitates back into the left atrium, then you listen to the murmur. So now, when the individual is doing a maneuver which will increase the venous return, what has happened to the quantity of the blood on the left side? The quantity of the blood is reduced. So when the quantity of the blood is reduced, the amount of blood which will be regurgitating back into the left atrium is also reduced. So that is the reason why the murmur is shortened. Next. Now let me tell you, or let me take up a clinical scenario where there is decrease in the venous return. Now, what are the maneuvers which will decrease the venous return? The maneuvers which will decrease the venous return are, number 1, standing from supine position. Right, standing from supine position. The other one is Valsalva maneuver. Right? So these two maneuvers will reduce the venous return of the individual. Now, let me tell you what will happen when the venous return is reduced. The point is, when the venous return is reduced, that means the amount of blood on the right side is reduced. So where do you think the blood is now? The large quantity of the blood is on the left side of the heart. In this clinical scenario, right? In this clinical scenario, what will happen to the click? The click, it becomes early, And what will happen to the murmur? Murmur is prolonged. Right? Murmur is prolonged. So this dynamic auscultation is the one which differentiates the click of mitral valve prolapse from the clicks of the other cardiovascular pathologies. Alright. Next. Now let me discuss the complications of the mitral valve prolapse. The complications include, number 1, mitral regurgitation. Number 2, the ventricular premature beats can throw an arrhythmia. Right? If more than 3 ventricular premature beats are occurring continuously, then we can use the word arrhythmia. Now, these individuals, they can have sudden death. So, why do you think they have sudden death? Because if the individual develops ventricular arrhythmia, they can have sudden death. Right? Next, the other thing is they can have transient ischemic attack. I have explained you why they can have transient ischemic attack. And these individuals, they can also develop the infective endocarditis because the prolapsed valves, they may be the source of seat of infections. Why? Because a jet of blood is hitting the prolapsed mitral valve and entering into the left atrium. So a jet of blood, when it is hitting back the prolapsed mitral valve, there may be rupture of these particular valves. And once the valves are slightly ruptured, that can act as the seat of source of infection to the microbial organisms, right? So these are the complications in the patients with the mitral valve prolapse. So now let me discuss how do you investigate these patients of the mitral valve prolapse. As already I have said you, it is by 2D echo. Now, the multiple choice question that will be asked is, in the 2-dimensional echocardiography, right, now you see this question, true regarding mitral valve prolapse is all except, more common in females, it's a correct point, mostly symptomatic, it's an incorrect point, high incidence of arrhythmias are there, transient cerebral ischemia can occur, right? So remember, most of these patients with the mitral valve prolapse, they are not symptomatic, they are asymptomatic and they are accidentally being diagnosed. So the answer there is B. Now let me show you the 2D echo finding or 2D echo of the mitral valve prolapse. So you can see this particular arrow over here, right? This tells that the mitral valve leaflet is prolapsing into the left atrium. This is the left atrium and this is the left ventricle and this is the right atrium and this is the right ventricle, right? This is the apical 4-chamber view in 2D echo, right? Apical 4-chamber view in 2D echo. Is that clear? Now, when can you use the word prolapse? That means how much should be the minimum amount of the mitral valve that is prolapsing. Remember, if the distance between, right, if the distance between the mitral valve annulus and as well as the prolapsed area, right, if the prolapsed area, if it is more than 3 mm, this will be the multiple choice question, right? If the mitral valve, if it is prolapsing more than 3 mm beyond the mitral valve annulus into the left atrium, then we use the word mitral valve prolapse. Now, let me discuss the treatment in these patients, right? Let me discuss the treatment in these patients. As such, most of these patients are asymptomatic, they don't require a treatment. But in those individuals where the palpitations are very common, for them, you need to give the beta blockers, right? You need to give beta blockers. So why do you want to give beta blockers? Why you have to give beta blockers is, now first you should know why they are having palpitations. Why are they having palpitations? Because of the ventricular premature beats. So you suppress that ventricular premature beats with the help of these particular beta blockers and the palpitations will reduce, right? Next, the other group of drugs which are required is diuretics. Now, why do you think they require diuretics? Because the point is, whenever the mitral valve prolapse is associated with severe mitral regurgitation, then the individual can have pulmonary edema, due to which, for which you have to give the diuretic. right? And the other point is, the other drugs what they require is antiarrhythmics. Right, the other drugs what they require is antiarrhythmics. Now why you should give antiarrhythmics? Because as I have said you, one, these patients can develop atrial fibrillation, or these patients can develop ventricular fibrillation, for due to which they can have sudden cardiac death, right? So for that reason you have to give antiarrhythmics like cardarone, that is amiodarone should be given. Next, aspirin is another drug what you have to give in these individuals. Right, why you have to give aspirin? Because these patients with the mitral valve prolapse causing severe mitral regurgitation, if they develop atrial fibrillation, there may be chance of the clot formation. So in order to prevent that, you have to give aspirin, or in order to prevent the transient cerebral ischemia or stroke, you have to give aspirin. But all these you need to give when the individual is having severe mitral regurgitation. Next, now there is a significant atrial fibrillation in the individual, and there is a clot which has been formed within the left atrium. Now, in such case, you have to give even anticoagulants. Right, in such case, you have to give anticoagulants. Is that clear? Next, lastly, if the individual is having severe mitral regurgitation, and that too, if the individual is an elderly individual, they require mitral valve replacement, right? They require mitral valve replacement. So this completes the discussion on the mitral valve prolapse. So let me shortly revise about the mitral valve prolapse. Right, mitral valve prolapse, this is also called as the Barlow syndrome, or billowing mitral valve, or floppy valve syndrome. All right. Next, the very important point is, this mitral valve prolapse is most commonly seen in females, and that too young females, and rarely it can be seen in elderly individuals. And if it is seen in elderly individuals, it is very common in case of males, and that too it is associated with the mitral regurgitation. And this mitral valve prolapse is commonly seen in those individuals who are having Marfan syndrome, and in 20% of patients they can have associated ostium secundum type of atrial septal defect. And if you see the clinical features, the palpitations are the most frequent symptom, and that is because of the ventricular premature beats. And these individuals, they can have atypical chest pain. They can also have the neuropsychiatric symptoms in the form of the panic attacks or anxiety attacks. And these individuals, they can also have transient cerebral ischemia and as well as stroke. And auscultation, that is on examination, the auscultation is very important, wherein these individuals will have a mid-systolic click, that too multiple clicks, and they will be also having a late systolic murmur. And you should be able to differentiate this particular mid-systolic clicks from the other conditions by doing a dynamic auscultation. Next, the complications are, they can have associated MR, they can have arrhythmias, they can develop sudden cardiac death, and these individuals, they can also have transient ischemic attacks and as well as stroke. And the diagnosis is mainly by two-dimensional echocardiography, and if the valve is prolapsing more than 3 mm from the baseline, then we use the word MVP. And the treatment is, like, you need to give the antiarrhythmic drugs, beta blockers, aspirin, blood thinning medications. All these you need to give once the individual develop the complications like MR and atrial fibrillation and clot formation. And if the individual is elderly individual, and if the individual is having very severe mitral regurgitation and that too symptomatic, then you have to go ahead with the mitral valve repair or mitral valve replacement.